Hey Sam, are you ready to review the shoulder complex for our exam? We need to master the anatomy and physiology to truly understand the biomechanics later.
Definitely. Let's start with the bones. The shoulder complex isn't just one joint. It relies on the clavicle, scapula, and humerus.
Right, and those bones form four distinct articulations. There is the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic functional joint.
The sternoclavicular joint is fascinating because it is the only true bony attachment connecting the upper limb to the axial skeleton. It has an articular disc inside to absorb shock.
Whereas the glenohumeral joint is a ball and socket joint designed for mobility over stability. The humeral head is large, but the glenoid fossa of the scapula is remarkably shallow.
Exactly, the glenoid cavity only covers about 1/3 of the humeral head. To fix that anatomical mismatch, the glenoid labrum, a fibrocartilaginous ring, deepens the socket by about 50%.
Even with the labrum, the joint capsule itself is quite lax to allow for massive ranges of motion. The physiological trade-off is a heavy reliance on passive and active stabilizers.
For passive stabilizers, we have the superior, middle, and inferior glenohumeral ligaments, along with the coracohumeral ligament. They tighten at different endpoints of movement.
But the real heroes are the active stabilizers, the rotator cuff muscles. Let's list the sits muscles and their anatomical roles.
Supraspinatus originates in the supraspinous fossa and inserts on the greater tubercle. It initiates abduction and pulls the humeral head snugly into the glenoid cavity.
Then infraspinatus and teres minor both occupy the posterior scapula and insert on the greater tubercle too. Physiologically, they produce external rotation and depress the humeral head.
Don't forget subscapularis. It is the only one on the anterior surface, filling the subscapular fossa and inserting on the lesser tubercle to handle internal rotation.
Together, their tonic physiological contraction creates a dynamic stabilization effect. They actively pull the humerus into the socket, counteracting the upward pull of the deltoid.
Speaking of the deltoid, its three heads, anterior, middle, and posterior, have massive leverage because they insert lower down on the deltoid tuberosity of the humerus.
Speaking of the deltoid, its three heads, anterior, middle, and posterior, have massive leverage because they insert lower down on the deltoid tuberosity of the humerus.
We also have to look at the scapular muscles. The trapezius, serratus anterior, rhomboids, and levator scapulae change the orientation of the glenoid fossa by moving the scapula.
The serratus anterior is crucial. It originates on the upper ribs and inserts on the anterior medial border of the scapula, keeping the bone flat against the thoracic cage.
If that nerve supply, the long thoracic nerve, fails, the physiology changes and we see scapular winging.
Let's talk about blood supply and nerves. The axillary nerve wraps right around the surgical neck of the humerus, making it highly vulnerable to dislocations.
And the primary arterial supply comes from the subclavian artery, which becomes the axillary artery, giving off branches like the anterior and posterior circumflex humeral artery.
Perfect. If we understand how these bones, ligaments, muscles, and nerves structurally align, analyzing abnormal shoulder mechanics in the clinic will be a breeze.